Welcome everyone to our webinar, Interdisciplinary and Evidence-Based Approaches to Supporting Management of Diverse Fall Risk Factors Among Community-Dwelling People with Multiple Sclerosis, facilitated by the Fall Prevention Community of Practice. My name is Mariel Ang, and I am the Project Coordinator at the Ontario Neurotrauma Foundation. ONF supports the Fall Prevention Community of Practice and its online platform called Loop. Loop is a place where fall prevention practitioners connect. Visit us at www.fallsloop.com. Marguerite Thomas also joins us on the line. Marguerite is the coordinator for the Fall Prevention Community of Practice. She will be assisting with facilitating questions in the chat box today. Before we begin, I'm going to give you a quick rundown on the Level 3 meeting system. This webinar technology consists of two parts. The audio is provided through a telephone conference line, and the visuals are provided through a web platform. The phone number for the conference line and the link to the web platform were sent to you by email after you registered for the webinar through Level 3. If you have questions about the technology at any time during this presentation, please type them into the chat box on the left-hand side of your screen. Alternatively, you can email me at mariel@onf.org. That's MARIEL@onf.org. I will work with you to resolve technical issues as soon as possible. This webinar will contain opportunities for participation. There will be online polls throughout the presentation, which you will answer directly on your screen, and a question and answer period at the end. If you have a topic-related question during the presentation, please type them into the chat box. During the Q&A, questions will be read aloud to the group. If you would prefer to ask your question over the phone, we will provide the instructions to unmute your line during the Q&A. The webinar is being recorded, and a YouTube link will be sent to all participants in about 1 week along with the presentation slides. I would now like to introduce our presenter, Liz Peterson. Dr. Elizabeth Peterson is a clinical professor and director of professional education in the Department of Occupational Therapy at the University of Illinois at Chicago. Her research interests over the past 20 years have focused on falls and fear of falling, epidemiology, measurement, and interventions for community-dwelling older adults and people living with multiple sclerosis. Her early work as a member of the Boston University Roy Ball Center team led to the development of the Matter of Balance intervention. Dr. Peterson is a fellow of the American Occupational Therapy Association. She is an original member of the National Council on Aging's Falls Free Coalition, a founding member of the International MS Falls Prevention Research Network, and she is currently leading the Illinois Fall Prevention Coalition. Without further ado, please take it away, Liz.
Hi, everybody. Hello, everybody. Thank you for joining our webinar. I really appreciate this opportunity to share a number of findings from our different studies over the years, and eager to show the practical implications of those findings. I am an advocate for interprofessional collaboration, so I have created this presentation for interdisciplinary audiences and look forward to everybody's participation. A special thank you to Mariel and Marguerite Thomas for helping to organize this. So looking ahead, as we think about our objectives today, the first thing we're going to do is we're going to draw from a number of sources to justify why attention to diverse fall risk factors among people with MS warrant your attention. We're going to talk a little bit about physical risk factors for falls among people with MS, and then identify examples of environmental, psychological, activity-related, and behavioral influences on fall risk among people with MS based on the research to date. And one of my goals is really to help our participants develop a repertoire of strategies that they can use with other members of the interprofessional team to address these different types of risk factors. So one thing I want to mention from the start is that the focus of this presentation will be on community-based people with MS, and those are, we're going to be focusing on community-based individuals who do not have significant cognitive impairment, and this is the population that has been most widely studied in the MS fall research literature. So to give you a sense of the road ahead, I'm going to begin with an introduction to the problem of falls among people with MS and describe some key physical risk factors based on systematic reviews and meta-analyses to date. We'll spend a little bit of time talking about some foundational concepts that provide a good justification for attending to diverse types of fall risk factors in this population. And then we'll transition to looking at environmental influences, psychological and activity-related influences, and behavioral influences on fall risk. And we will end with a summary. So let's start by just thinking broadly about this problem of falls among people who are living with multiple sclerosis. I'm sure many of you are aware that MS is a chronic, frequently progressive, demyelinating disease of the central nervous system. One thing that's important for us to keep in mind is that in the United States, 45% of people who are living with MS are older than 56 years, and that is the case worldwide. So what that means is that individuals are aging and living with MS at the same time. So that provides sort of an interesting level of challenge, but some opportunities there too. We know that MS results in a wide range of impairments as well as activity and participation restrictions. MS fall prevention research is definitely gaining momentum, but I would say that overall we are still in an early phase. So just to give you a little bit of history, Dr. Davide Catania led the first study of fall risk factors among people with MS in 2002. Dr. Marcia Finlayson, who is a professor at Queens College in Kingston, and I followed with the study in 2006. I completed my PhD focusing on falls among people with MS at the Karolinska Institute in 2009. So this slide was created by Dr. Finlayson, and it speaks to the dramatic jump in articles about falls among people with multiple sclerosis between 2002 and 2014. I think it really speaks to the value of collaboration. Much of the work that has occurred in this particular area of research has been supported by members of the International MS Fall Prevention Research Network. Dr. Finlayson initiated that collaboration with funding from Queens College, and of course I'm happy to be one of the members of that group. This jump in interest in falls among people with MS also reflects a growing recognition that while many lessons learned can be taken from the geriatric literature, the unique fall risk factors among people with MS need to be better understood and addressed. So over these years, we have learned something about epidemiology of falls among people with MS. For example, we found that 56% of people with MS fall each year, and the number of frequent fallers is definitely striking. Fall-related injuries are common, as is fear of falling. One study that I conducted involving people who were aged between 45 and 90 found that almost 64% of people reported fear of falling. And among people who are reporting fear of falling, 83% are reporting that they're cutting back on activity because of that fear. An important study came out in 2015 that demonstrated that lower fall self-efficacy was associated with future recurrent falls independent of past recurrent falls among people with MS. I will be coming back to that point in a little bit more detail. So let's look at some of what we found from systematic reviews and meta-analyses regarding fall risk factors. Take a look at this slide and take a moment to reflect on what you see in terms of the findings. So this slide was created by Michelle Cameron, and it reflects studies undertaken by Gunn, Gianni, and Nilsgaard. So it's a really nice summary. And you can see that of studies done to date to look at risk factors, physical risk factors are very well represented. You can see many impairment level risk factors appearing. Certainly balance and gait-related risk factors are well represented, and I do need to emphasize that balance is a very important fall risk factor among both people with MS and, of course, older adults. So as you look at this slide, you'll notice there's only one environmental or behavioral characteristic, and that's use of a walking aid. So we'll be coming back to this point too and looking at what might be behind that particular risk factor. So let's move on and talk a little bit about some foundational concepts and evidence supporting attention to diverse risk factors. So what I mean by diverse would be risk factors beyond physical risk factors, but really a variety of types of risk factors, be they attitudinal, environmental, behavioral. So first we're going to, just in terms of an overview, I'm going to draw a little bit from lessons from gerontology, specifically from the American and British Geriatric Society guidelines for the prevention of falls in older adults. I'm going to talk briefly about the World Health Organization's ICF as a source of inspiration. And for the OTs in the audience, I'm going to draw from just a couple of resources to highlight the OT perspective and how that supports looking at diverse risk factors. And finally, I'll look at some lessons from a recent study examining stakeholders' views. So here we have our first poll. And the question is, have you heard of the American and British Geriatric Society guidelines for the prevention of falls in older adults? So we'll pause, and I'll ask people to indicate yes or no. And I can see the responses coming in. Let's give a little bit more time. Okay, so far we have 32 people indicating that they have not heard about this document and 8 people indicating that they have. So this is fairly typical, and I think that it is worthwhile for people to take a look at this published resource. This is a resource that focuses on a summary of the evidence for fall prevention among older adults, and it's both published and it's also available on the web. And the reason I'm coming back to this particular document is that when we think about lessons learned from geriatric literature, this document certainly demonstrates that there is evidence supporting a holistic view of the influences on fall risk that encompass physical, behavioral, attitudinal, and environmental risk factors. It is widely recognized that falls among older adults are typically caused by diverse and interacting risk factors. And among older adults, the risk of falling actually increases dramatically as the number of risk factors increases. So this finding has been demonstrated through a number of studies that involved older adults and informed the multifactorial risk factor abatement strategy that is endorsed by the American and British Geriatric Society. I suspect that people have heard about the U.S. Centers for Disease Control STEADY initiative. That the STEADY acronym stands for Stopping Elderly Accidents, Deaths, and Injuries. It too is available through the CDC website. So you might be interested to know that the CDC STEADY initiative was based on the American and British Geriatric Society guidelines, and it's basically a distillation and in some cases an expansion to support practitioners in their efforts to quickly assess for fall risk. And there's a number of great resources to check out if you haven't been to that CDC website. So I would say that although MS fall prevention research is young compared to older adult fall prevention research, and I know we need to be careful about generalizing findings, I would say that the value of addressing diverse and modifiable risk factors is widely recognized by MS researchers and clinicians alike. So to help understand how a risk factor abatement strategy works in fall prevention, imagine that you're building a tower of bricks with one brick stacked up on the next. And each brick represents one risk factor. It could be physical, environmental, or behavioral. So as the tower gets taller, it becomes more unstable. Likewise, when your risk factors stack up, your risk of falling increases. So the goal of this risk factor abatement strategy is to shrink the tower. So you may always have some bricks or risk factors, especially since some risk factors, like having already fallen or getting older, cannot be changed. But we can shrink the tower and thereby reduce the risk for falls. So it is important to remember, however, that the process starts with identifying modifiable risk factors. So failing to consider environmental, behavioral, or activity-related fall risk factors will compromise the effectiveness of our intervention efforts. So the risk factor abatement strategy underlies the logic behind many multifactorial fall prevention interventions, and I'm sure this group is very familiar with many of these interventions that have been provided for older adults. And again, I think we have some lessons from gerontology that we can draw from here. So when we think about multifactorial interventions, what we're talking about are interventions wherein the clients receive different combinations of interventions. They're carried out by healthcare professionals that are qualified to deliver those interventions based on the findings from the individual assessment. So we're looking at individualized interventions that reflect modifiable risk factors, as well as the client's readiness to change, their abilities, their goals, and of course their physical and social context. So I think this is important to kind of keep in mind as we think about some foundations for work with people living with multiple sclerosis. I mean, this sounds very obvious, but one of the critical lessons from gerontology is that you have to follow through with plans to address modifiable risk factors in order to see any benefit from that. And that honestly can be more challenging than it appears to be sometimes. Following through certainly includes referring to members of the interdisciplinary team, as well as supporting clients and building relationships with community-based service providers, and supporting the client's ability to develop and use self-management skills. I'll be talking a bit more about self-management later in the presentation. So let's think a minute about the World Health Organization's ICF and how it provides an interesting foundation for fall prevention efforts focusing on people living with multiple sclerosis. So the ICF is both a classification system and a conceptual framework for describing and measuring functioning in society. It emphasizes that disability emerges through a relationship between the individual who has a health condition and contextual factors, such as personal or environmental factors. So personal factors include self-efficacy. So the ICF reminds us that impairment level influences on fall risk are absolutely important, but they are not the whole story. So for the OTs in the audience, I just want to reference the AOTA practice framework. The framework is a good reminder that in addition to restoring or fixing impairments, OTs have a variety of tools at their disposal. So a focus on maintenance or compensatory skills is of course important to other healthcare providers too, because people with MS live with some type of impairment often. It could be a balance impairment, fatigue-related challenges, or vision impairments. And so we know that we may not be able to eliminate all those physical risk factors, but we can help a person establish new habits that support safe engagement and valued activities. So the key underlying idea is how can we best support people with MS in their efforts to engage in a meaningful activity on a day-to-day basis in a way that supports their own safety and well-being. So the other occupational therapy related reference that I'll make today is reference to the PEO framework. I think this also provides a very nice worldview for fall prevention work involving people with MS. This person, environment, occupation framework has been a very useful tool that Dr. Finlayson and I have used in our fall prevention research to conceptualize fall risk as dependent upon the intersection of the person, the environment, and the characteristics and demands of activities or occupations that are being performed at the time. So in the next few slides, I'm going to talk briefly about a pilot study that I conducted with Dr. Finlayson. This was a fall risk management program specifically designed for people with MS. And the reason I'm spending a little bit of time here is that this particular pilot has become a good inspiration for future projects, intervention work going on, for example, in Ireland and also in Illinois. And also I think that it will help to inform some clinical efforts, but I do want to highlight that it was a pilot. So this pilot study, again, looked at the outcomes of a fall associated with a fall risk management program, specifically for people with MS. And some of the key guiding principles that we used were to attend to PEO factors. We emphasized the use of experiential activities to promote not only knowledge but also skill mastery. This was a group intervention, and we recognized that providing a supportive and safe environment that enabled participants to practice and refine their fall prevention skills was important. Also, a safe environment to discuss their concerns about falling and the challenges they have in managing their fall risk. So sharing and problem solving, self-assessment, and reflection were key components of this intervention. So one thing that we did that I think was quite successful is that we created an acronym called BAASE to help capture attention to a variety of different types of fall risk factors: behaviors, attitudes, activities, symptoms, and the environment. We also recognized that we were hoping to teach our participants skills that would be generalizable into future situations that could possibly challenge their risk for falls. So we recognize that fall prevention efforts need to be ongoing, so we were eager to provide our participants with a skill set that they could use over time as their fall prevention needs change. So we'll pause here and take another poll, and I'm going to ask how many of you are familiar with self-management interventions, such as Kate Lorig's chronic disease self-management program? So I'm just looking at the responses come in. Okay, so we have 34 people who are not familiar with Kate Lorig's chronic disease self-management program and 8 people who are. So self-management is a paradigm that really supports individuals who are living with chronic health conditions. And I'll just start by saying that when you think about fall risk, anybody who's had one fall is at much greater risk for falling again. So people who have had a fall in the past basically are facing a chronic fall risk. So our Safe at Home based intervention drew from a variety of self-management skills to support our participants in their efforts to manage their fall risk. So I'm eager to refer you to some of the resources that are included in the reference material that are provided in association with this webinar, and you'll find some resources there on self-management. But self-management skills briefly include problem solving, decision making, finding and using resources, helping participants form patient-provider relationships and partnerships, action planning, and self-tailoring. So I'm going to leave it there in terms of talking about self-management interventions, but really encourage people to look into it because it's a very valuable foundation for fall prevention. And I'll mention that in developing the Safe at Home base program specifically for people with MS, I did draw from my experiences with the Matter of Balance intervention. Matter of Balance is an intervention designed for older adults that draws also from self-management principles, and that intervention is designed to help people manage their concerns about falling and safely increase their activity levels. And that intervention is now the most widely implemented fall prevention intervention in the United States, and it has been tested through 2 randomized trials. So as we're thinking about lessons learned from gerontology, I think drawing from these experiences and the value of self-management is worth considering. So we had some very positive outcomes, and I know you have the slides and you'll be getting them, so I won't go into them with too much detail. But we did find significant pre-post differences for falls self-efficacy, falls control, falls management, and a fear of falling item that we created. We also created something called the Falls Prevention Strategy Scale. So I'll call it the FPSS. This instrument was developed specifically for the pilot study and is now available for clinical use. It is an instrument that allows us to look at strategies used, in this case before the program was launched, and strategies used after, and the effectiveness of the strategies that were used afterwards. So the fall prevention strategy scales enables the user to look at the percent change in use of strategies before and after the program. That would be like the number of people reporting no before, but yes after. So you can see we had some very nice positive changes for these behaviors in our intervention. Okay. So before transitioning to part 3, I just want to highlight some lessons learned from a fairly recent study looking at stakeholders' views of in the development of a balanced, safe mobility and falls management program for people with MS. So this study was conducted by colleagues in England, and you'll see one of the important points made by the target audience was that the program should support the development of both coping strategies and self-efficacy. So I thought that was a nice additional piece of evidence supporting the value of self-efficacy, because when we look also at self-management programs and we look at the ingredients that make self-management programs effective, this self-efficacy piece is very, very important. So basically improving individuals' confidence in their ability to self-manage their fall risk. Very important. So let's look at some environmental influences on fall risk. And we're going to talk both about the physical environment and the social environment. So when we think about some lessons learned from gerontology, we're going to kick it off with another poll. And I'm going to ask you guys to answer this one. Comprehensive home safety assessment and modification interventions for community dwelling older adults involve, first of all, could it be considering all potential hazards? That means older adults' awareness of their environment, older adults' awareness of how to negotiate the environment, problem-solving solutions, or all of the above. Everybody's getting this one right. Certainly when we think about interventions designed to improve home safety, it includes much more than just a checklist of the hazards that are in existence. It's very important to involve the participant in the process of problem-solving solutions and looking at sort of that intersection between the environment and the extent to which it fits the person's needs and promotes their independence. So thank you for acknowledging that. And I certainly think that checklists are important. They have a role, but walking through a home and identifying fall hazards is certainly not enough to reduce fall risk. And I would like to acknowledge the work of Dr. Lindy Clemson from the University of Sydney in her efforts to highlight the complexity of environmental interventions. So one of the first examples of an environmental risk factor that I'm going to highlight would be multiple mobility device users. Okay? So it's widely recognized that people who are living with MS use a wide variety of different types of mobility devices, right? And what we found in one study was that people with MS who used a mobility device had a higher risk of falls in the systematic reviews that were conducted by Gunn et al. Okay? We certainly know that, again, prevalence of mobility device use is high. And one thing that's interesting is that it's very common for people with MS to use more than one mobility device. Okay? So in a study that I undertook with my colleagues Marcia Finlayson, Einat Benari, and Miho Asano, we were looking at the relationship between multiple mobility device use and fall status. And what we found was that the number of mobility devices used was one of 4 variables that was found to be significant in the regression. Not only that, but we found that the higher the number of mobility devices used, the greater the likelihood of being a faller. So this, I think, has some important practice implications. We should definitely be asking about all the devices that an individual is using, not just the primary one being used. As we conduct comprehensive fall risk assessments, think about those technical, physically oriented skills related to walking, as well as problem solving, decision making, and activity analysis skills. And so what I mean by that is promoting problem solving, decision making, and activity analysis among the participants so they are able to better select and use the proper mobility device in the right situation. It's also important to provide education to help people with MS select the correct device and practice their skills over time. I'm involved with colleagues at the University of Illinois in Champaign-Urbana that's really focusing on providing refresher courses to people with MS to help them build transfer skills long after they've completed outpatient OT or PT or even inpatient rehabilitation. Unfortunately, in the United States, our healthcare system is not set up to allow these type of refresher courses, but I think refreshers on how to appropriately use mobility devices and also to kind of recognize and help assess when new types of mobility devices are needed are really important. So I mentioned that the World Health Organization's ICF and the person, environment, occupation models reminded us of the importance of not neglecting social and cultural environments. So the impact of these aspects of these aspects of the environment on fall risk are often understudied, but I do have some insights to share on this subject. So this slide describes a study that I undertook to explore the lived experience of people who have MS, their lived experience of fall self-efficacy, and its relationship to their overall volitional and occupational lives. So this was a qualitative study, and the analysis generated a meaning structure of the lived experience of fall self-efficacy that included the sub-theme, taking personal risk to reduce fall risk. Taking personal responsibility to reduce fall risk. So the participants' lived experience of fall self-efficacy was certainly oriented to taking action to reduce fall risk in the course of daily activities. So what we found in general is that the participants' ability to apply fall prevention strategies quickly, even in new situations, was quite striking, and many of these actions involved changing, adapting, or utilizing both the physical and the social environment. Importantly, each participant saw him or herself as leading efforts to reduce fall risks that were inevitably operating in day-to-day life. And it was clear in our study that the participants felt that if social networks were going to be utilized, it would be done on their own terms. So I think the important practice implications emerging from this study is that it is very important for us to look at current use of both formal and informal supports. It's important to educate clients about available supports such as MS support groups, and also we can support people with MS in their efforts to engage their social networks on their own terms. So we're going to transition now and think about some psychological and activity-related influences on fall risk. So starting with some big picture ideas, when it comes to activity, unfortunately, there is strong evidence that indicates that people with MS are largely sedentary. The barriers to activity for people with MS are well documented and range from inaccessibility to climate and social barriers. But let's take a moment to think about how important activity and exercise are to people with MS. So Stoifbergen demonstrated that decreases in physical activity were associated with the trajectory of functional decline. So both exercise and day-to-day or lifestyle activities are important. And when you think about motivating factors, sometimes people are more motivated by activities that are valued by them as opposed to exercise. So both are equally very important. With respect to exercise and fall prevention, the review completed by Dr. Jacob Sesnoff that included 10 studies showed that exercise-based interventions targeting with MS often resulted in a reduction of falls or a proportion of fallers. So of the 10 studies that were reviewed, 9 of them showed promise in terms of reducing falls. So it's another point to kind of highlight the importance of exercise. So I'm showing you this slide to highlight that the frequency and the nature of activities that people with MS engage in are incredibly diverse. As healthcare providers, we can guess some of the typical things that people might do with respect to ADLs, but once we start looking at IADLs and leisure activities, the natures of activities that people are engaging in are quite broad. So this is a reminder of the importance of teaching generalizable skills, the value of self-management skills in particular. And since self-efficacy is so critical to self-management interventions, this is a nice segue to talk a little bit about self-efficacy. So self-efficacy is defined as an individual's judgment about being able to perform a specific behavior. We know that many adaptive, healthy behaviors are important to preventing falls. And we know that research on achievement, motivation, and performance has clearly demonstrated that attitudes and beliefs affect behaviors. For example, a sense of control affects choice and effort, meaning persistence in challenging situations. So looking at the value of self-efficacy, it has become a very important outcome in fall work, both research and clinical practice. And Mary Tinetti originally created the Falls Efficacy Scale to operationalize fear of falling and to measure it in older adults. And this concept of fall self-efficacy has been used in the MS fall prevention literature. And as I mentioned at the top of this presentation, in 2015, Matt Zoomer demonstrated that falls self-efficacy measured by the Falls Efficacy Scale International was associated with future recurrent falls. In this case, it would be lower falls self-efficacy was associated with recurrent falls, independent of past recurrent falls in people with MS. So I'm glad to offer a tool that can be effectively used to assess falls self-efficacy among people with MS. The Falls Efficacy Scale International comes in 2 versions. There's a 16-item version and a 7-item version. This is available. You can usually find it on the internet. And there's a European group called the Profound Group that also, where they were the developers of it. We know that the 7-item version actually has better psychometric properties for people with MS than the long version, but both can be used. So when you're thinking about fall self-efficacy, right, it's important to assess the extent to which your client's level of fall self-efficacy is protective and that it's serving as a red flag to keep people from engaging in risky activities, or if it's leading to undue activity curtailment. So I use tools like the Falls Efficacy Scale as a starting point. And I think that these self-report tools help us get a better sense of the personal impact of perceived fall risk, and they're also quite quick to administer. Important to note that this type of self-efficacy tool is not going to replace a performance-based measure. Of course, both objective and subjective measures are important. So let's transition, and I'm going to introduce 3 slides that really highlight the importance of looking at activity levels and participation as key outcomes for fall prevention interventions. So the first slide to make this point is a study that came out in 2017 that was looking at falls among people with MS and their experiences in 115 different fall situations. And the participants in this study said it was more important to remain as active as possible than to stop doing the activities. So avoiding activities, according to these participants, would significantly constrain their everyday life. So there you have a first-person view of the importance of activity. So when you think about marketing fall prevention interventions, think about highlighting the outcome of engaging activities that are important to them. So this was also echoed in the qualitative study that I described earlier that was looking at the lived experience of fall self-efficacy. So the central theme that emerged, which was managing fall risk as a means of supporting activity, reflects that the participants emphasized that their main goal was not to avoid falling, but rather to fulfill roles and participate in life activities that were important to them. So the implications here are to frame fall prevention efforts in the context of fulfilling roles and engaging in valued activities. Definitely measure participation. I have some suggestions to offer. And create activity-based opportunities for participants to try out and build their fall prevention skills. So here are several tools that have been validated with people living with MS and can be used to measure participation. So as a clinician, when you're thinking about the outcomes of your interventions, measuring participation is a very logical outcome to assess in the context of fall prevention interventions. So just to wrap up this section, we know that occupational priorities are highly individualized among people, and that OTs often have a key role in identifying those priorities and helping to narrow the gap between task demands and capability. So when you're thinking about your fall prevention team, remember to involve occupational therapists, and all healthcare providers can, I think, help motivate people with MS to engage in fall prevention efforts by highlighting the benefit to them in terms of their ability to safely engage in activities that are important to them. So as we come into the home stretch, we'll talk a little bit about behavioral influences on fall risk. And we know that there are both protective behaviors related to fall risk and behaviors that actually work against us in terms of reducing our fall risk. But here are a couple references that highlight some of the work that we've done in this area. So let's take a minute to give everybody an opportunity to write down one example in the chat box of a behavior that a person with MS could engage in that would support their fall prevention efforts. So we'll use that chat box and give people an opportunity to think about a protective fall risk behavior. So we have Karen saying report wearing supportive shoes. I would agree. Michelle, talking about consistent use of a gait aid. Yes. And often, there can be stigma associated with that, so addressing that up front. Bailey's writing, attending exercise classes, excellent, to get at the balance and strength necessary to reduce fall risk. Irma writes, using hip protectors, interesting. I have definitely done some work in hip protectors, and for frail individuals, they can be very important. Again, exercising, turning on the lights, right? Attending balance classes. Good. Assessing medications with the pharmacist. Excellent. Taking time and not hurrying. Very good. Jacqueline wrote wearing your leg brace when you're supposed to. And Linda wrote asking for help. Excellent. So individuals who look at asking for help as an assertive trait that will empower them is, again, a very, very good example of a fall risk behavior that's protective. So I mentioned the fall prevention strategy scale, and just want to say a couple more words about this. So it's an 11-item scale that forms a unidimensional set of items that these items encompass a varying level of difficulty, and they're relevant to people with MS regardless of their mobility level. So the way the fall prevention strategy scale is set up is that, as it's listed, we did a Roche analysis. The first item was the easiest to endorse in our study, and in our initial study, the 11th item was the hardest to endorse. So the fall prevention strategy scale is determined by assigning a score of 0 for items that subjects reported never using, a score of 1 for strategies used sometime, and a score of 2 for strategies that are used regularly. So the total score is the sum of the score for all of the 11 items, and the resulting minimum score would be 0 and a maximum score of 22. So here are the 11 fall prevention strategy scale items. And it's been actually kind of fun to use a fall prevention strategy scale in a number of studies about fall risk. So for example, Michelle Cameron used the fall prevention strategy scale and found that both fallers and non-fallers rarely talk to their healthcare providers about fall prevention. This we see among older adults also in that fall prevention literature involving older adults, and it highlights the importance of healthcare providers initiating those conversations about falls. Dr. Cameron also found that in her study involving people with MS, both fallers and non-fallers were rarely asking providers to check medications that might increase their fall risk. So I recognize as an OT, I am not an expert in pharmaceutical fall risk. However, I certainly can encourage people with MS to have their medications checked by healthcare providers with that expertise at least annually, and reminding them that it's not just prescription but also over-the-counter medications that need to be assessed together. So another study that was conducted by Dr. Cameron and her colleagues found that the mean fall prevention strategy scale for fallers was actually higher than the non-fallers. Interesting. So in other words, the people with MS who fell were actually using more fall prevention strategies than the people who didn't fall. So the implication there would be really to look at the fall prevention strategy scale as a starting point for conversation, and knowing that looking into the number of strategies is not enough. We have to know if these strategies are effective and also recognize that the strategies used may need to change over time. Big picture, we found that non-fallers were employing very few fall prevention strategies. So if you are fortunate enough to work with a person who has MS before they've fallen, be proactive and talk to them about different types of fall risk factors and how they can manage them. So I'm showing you this slide to highlight that when we looked at the different behaviors listed in the fall prevention strategy scale that were ordered by prevalence among people with MS who were fallers, we found that this issue of planning what to do in case a fall occurred was actually quite challenging for these people who were labeled as fallers. And so it helps to highlight the importance of creating fall management plans for people with MS. I've done some work with Etienne Bisson, who is based at Queen's College in Canada, looking at critical falls among people with MS. And unfortunately, we have found that critical falls, which are defined as an inability to get up after a fall, are quite common among people with MS. Interestingly, only a few people with MS in our studies had experienced a long lie. So perhaps these individuals did have fall risk management strategies in place, fall management strategies in place, but I think we can all work closely with people with MS to make sure that they do have these plans in place, assess the quality of them, and recognize that I know the period after a fall can be quite scary, but it also can be a teachable moment. Many falls actually don't result in injury, but they can be opportunities for sort of motivating people to take action to prevent future injurious falls. I think when it comes to fall management plans, it needs to be a collaborative effort. There's not a one-size-fits-all type of strategy. But we know that managing falls can be taxing emotionally. So this is where some communication strategies may come in handy. So when you're talking about challenging subjects, I just have 3 suggestions just to give you some ideas. You can draw from motivational interviewing strategies to ask permission, basically asking the client's permission before providing information, in this case about fall management plans or making suggestions. The ask, tell, ask strategy is a technique related to information giving. And as the name suggests, you first ask the client what he or she wants to know about a specific topic, in this case fall management. And then after the client's response, tell the information, and then ask again if he or she understood and what additional information he would like. And then closing the loop is an interesting communication strategy We know that when clients are asked to restate information, they're incorrect nearly half of the time. So closing the loop is a proven technique to improve health literacy. So by asking the client to repeat what he or she was just told is a way that the therapist can assess the extent to which the client has understood the information. So to wrap up this webinar, I think we've made several points to highlight that when we look at fall risk factors, they're very individualized but also diverse. And I think the diverse nature of fall risk factors really helps to create a mandate for interdisciplinary fall prevention for people with MS. And the fact that they're so individualized really highlights the importance of client-centered care. Teams can work together to understand clients' physical, social, and cultural worlds, the activities that they value, the behaviors that they engage in. And fortunately, we're at a point where we do have a number of resources to draw from to support each of you in your efforts to help people with MS manage their fall risk. And just a final reminder that identifying risk factors is not enough. Often self-management strategies can really be helpful to support people as they work on following through with mitigation strategies. And that's it. So I know we have some time for questions. I have a couple of resources that are on the concluding slides, and I know there's another document that highlights some resources. But these primarily focus on older adult fall prevention resources, but I'm sure you're all aware the National Council on Aging in the United States is an amazing resource. The CDC is a source of the study tool. And here at the University of Illinois, we have a project funded by our federal government called Engage Illinois. And Engage Illinois yields free continuing education for a variety of healthcare providers, including OTs, PTs, nurses, social workers, pharmacists, physicians, and they're on topics related to geriatrics. And of course, there is a module on fall prevention there, as well as many other interesting modules. So I would encourage you to check out the Engage Illinois website. Again, they're free for the next year, and they're beautiful CE courses that are done in a documentary style.
Wonderful. Well, thank you so much, Liz, for that great presentation. I will open it to the floor for some questions. Please feel free to type your questions in the chat box. And I'm just going to advance the slide once more, Liz, just to show your contact information. And so we have a couple of questions that are being highlighted in the chat box here. And Liz, I can read them out to you and you can answer. Sure. We have one coming in from Janice Bailey. Could you please define long line in terms of a timeline?
Sure. So when we were putting this study together, we recognized the importance of operationalizing long lie. So the way we defined it in our study was by describing long lies as falls that resulted in remaining on the ground for more than an hour after the fall. So again, it was an interesting finding that just under 5% of our 322 study participants had actually experienced a long lie, suggesting that maybe they do have fall management strategies in place.
Wonderful. Thank you. So we have another question in from Connie Neeson. Thank you for the excellent presentation of your research results. Would you say that many of your recommendations would also apply to those with other types of neurologic or chronic conditions?
Sure. Well, Connie is actually asking a question that was also asked by my dissertation committee during my dissertation defense back in 2009. So good question. I would say that it's very important to be careful about generalizing studies involving people with MS to other, populations of individuals with different types of neurological conditions. And so I kind of use the same, mindset. Like when I think about, for example, lessons learned from gerontology and how they might apply to people with MS, I think that they can help to inform some directions in terms of clinical work, but we have to be very careful about assuming that, the outcomes that we saw in interventions for older adults, for example, could apply to people with MS. But I just want to highlight that there are other sets of literature focusing on preventing falls among people who have Parkinson's disease and preventing falls among people who have experienced a stroke. And I know, for example, that Arlene Schmid, who's at she's at Colorado State University in the United States. She's done some really interesting work involving people living with a stroke and demonstrating yoga as an effective strategy to reduce fall risk and fear of falling in the stroke population. So in general, we have to be very careful about generalizing findings.
Great. Thank you for your answer, Liz.
Sure.
If there are any other questions, I'm just pulling up our questions slide here. It works best if you type your questions into the chat box, and that way we can select them for our presenter and read them aloud for everyone to hear. Alternatively, you can come on the line and ask your question directly.
And I guess I will say that because I'm either involved in intervention studies or know researchers who are involved in intervention studies, I will say that recruiting individuals who have MS in numbers needed to show a difference in our interventions, should those differences exist, is very challenging. So if you know of somebody who has MS that might be interested in participating in a study, feel free to send me that with their permission, of course, or that person could directly just contact me, and I can at least put that individual perhaps in touch with somebody in their country if I know of something going on.
Perfect. Thank you, Liz. And we do have some participants who are expressing some interest in that. So I think that's wonderful that you're able to connect those people with the right researchers as well. We've got another question in from Janice. What would be a good resource for us to provide for MS clients who want to do their own research into the disease, new medicines, new interventions, et cetera?
Mm-hmm. Well, I would recommend going to the National MS Society website. Honestly, that's my go-to source, and I'm sure that Canada has probably a similar body. So do you know offhand, Marielle, if there's a Canadian National MS Society?
Yes, I do believe there is. Let me just do a quick search right now.
Mm-hmm. But certainly in the United States, the National MS Society website is a very robust and evidence-based source of information. Of course, that's available to everybody, and the MS Society is extremely eager to support the resources that are available there and to disseminate them. So,
yep, it is the MS Society of Canada.
Okay, great. And I suspect that as in the United States, there are local MS chapters. I have been so impressed by the resources available to people with MS through their local chapters, and these supports can range from support groups to financial support to incorporate some home modifications. I know of individuals who have had their showers remodeled to allow them to be accessible by wheelchair with funding from local MS chapters. So something certainly worth looking into and a resource that clinicians can learn more about if they're working with people who are living with MS.
Perfect. Thank you so much, Liz. And I'm just being cognizant of time. I don't see any other questions that are coming up in the chat box, so I'll just take a moment to thank Liz again for a wonderful presentation. As well, thank you to all of our participants today for joining us and engaging in a great discussion. I found it especially interesting, and I'm so glad that you shared so many of your wonderful resources, Liz, because it did sound like from some of your polls that many of our participants hadn't heard of those resources before, so I think it's great, and I hope that everyone will find some utility after accessing those resources. I'm going to advance the slide here. For more information about the Fall Prevention Community of Practice, please visit Loop at fallsloop.com, and the website can be seen on your screens now. please don't close the window just yet. Wait until you've been redirected to the next screen where we will have a brief evaluation survey that will launch in your browser. And we'd really appreciate it if you could provide us some feedback so we can continue to offer high-quality webinars. And that is all for today. Thank you so much, and have a wonderful day. See you next time. Bye now.
Thank you, everybody. Bye.